Cardiopulmonary dynamics, exploring the essentials. Directly before jumping onto the physiology, it is very important to know the anatomy of the respiratory system. So it comprises of our bony thorax, then upper airway, lower airway, our ventilatory muscles, primary muscles as well as accessory muscles. Lungs are the main organs of our respiratory system. So there are two lungs in our body, left and right. Both lungs divide into lobes. Right lung has three lobes, upper, middle and lower. Left lung has two lobes, upper and lower. Now these lobes further divide into segments. Each lung has 10 segments. These segments are known as bronchopulmonary segments. Between two lungs there is our heart. Diaphragm is the main inspiratory muscle of our body. There are also accessory muscles which help the diaphragm to whenever there is increased work of breathing. Now let's understand about airways. So this structure that you can see over here, it is known as tracheobronchial tree. So trachea, our windpipe, it bifurcates and gives rise to two main bronchus, right main bronchus and left main bronchus. Now this main bronchus, they further divide and gives rise to secondary bronchi. They are also known as lobar bronchi because they supply to the lobes, okay, upper, middle and lower lobes. Now this secondary bronchi, they further divide into tertiary bronchi, also known as segmental bronchi, as they supply to the bronchopulmonary segments. Now this division continues and there comes bronchioles. Now up to bronchioles, these airways are known as conducting airways, as they only conduct the air. There is no gas exchange up to the level of bronchioles. After bronchioles, there comes respiratory bronchioles, and after respiratory bronchioles there is a structure known as alveoli or air ducts. Alveoli are the functional unit of our lungs, as they are the main structure that participate into gas exchange. That was all about the brief anatomy of our pulmonary system. Now let's discuss function of the pulmonary system. Basically it has three main functions. First and the most important is gas exchange. It is exchange of oxygen and carbon dioxide between environment, blood and tissue. Second is temperature homeostasis, means body temperature regulation. That is done by heat and water loss through our breaths. Third is filter and metabolize the toxic substances. Our lungs receive the blood from the right ventricle, okay, and right ventricle receives blood from the entire body. So directly or indirectly, our lung has the capacity to store the entire amount of blood that is in our body due to its vast capillary area. So now this blood, it gets filtered into our lungs. The lung has its own macrophages, lymphocytes and other immune cells. They participate in the process known as phagocytosis. That means they kill the toxic substances and bacteria and viruses that are present into our blood, and that is how our lung participate in filter and metabolization of toxic substances. Now in the physiology, we will discuss it into three broad categories. So first is ventilation, second is respiration, and third part is transport of gases to the peripheral tissues. Okay. Now what is ventilation? Ventilation or breathing, often misnamed respiration, It involves the mechanical movement of gases into and out of the lungs. Now what happens, sometimes we combine both these terms, ventilation and respiration, but they both are distinct from each other. They are very different. In ventilation, there is only mechanical movement of air in the lung. How air goes in the lung, how it comes out of the lung. That is our ventilation. So at rest, an adult breathes at the rate of 10 to 15 breaths per minute. That is basically our respiratory rate. And in each breath, we inhale the air of up to 30 to 500 ml. That is our tidal volume. Now what is minute ventilation? So it is basically the product of tidal volume and respiratory rate, which represents the total volume of air that is inhaled or exhaled in 1 minute. So at rest, when we are doing nothing, so our minute ventilation will be approximately 5 liter per minute. And while maximum exercise, it can increase up to level of 70 to 125 liter per minute as well. Now let's quickly revise the lung volumes and capacities. Tidal volume, as we have already discussed, amount of air that moves into and out of lung with each breath. Now what is inspiratory reserve volume? It is the additional volume of air that can be inspired forcefully after the end of normal inspiration. Its value is 3300 ml. Expiratory reserve volume. It is the volume of air that can be expired out forcefully after normal expiration. That is up to 1 liter. Residual volume. It is important among all these volumes. It is the amount of air that remains in the lungs even after the forced expiration. So basically our lungs never gets emptied, okay, completely, even after the forceful expiration. So there is some quantity of air that always remains in the lung even after the forceful expiration. Now why this residual volume has so much significance? Because it helps to aerate the blood in between breathing and during expiration, and it maintains the contour of the lungs. It prevents the alveoli from getting collapsed during expiration. Normal value for residual volume is 1.2 liters. Now lung capacities. Inspiratory capacity. It is the maximum volume of air that is inspired after normal expiration. That is end expiratory position. So it includes the tidal volume and inspiratory reserve volume. Vital capacity. It is the maximum volume of air that can be expelled out forcefully after a deep inspiration. So it involves the three lung volumes, that is tidal volume, inspiratory reserve volume and expiratory reserve volume. So the total value will be 4800 ml. Functional residual capacity. It is the volume of air remaining in the lungs after normal expiration, and it includes the ERV and RV. The value is 2200 ml. Total lung capacity. It is the volume of air present in the lung after a deep inspiration, and it includes the all volume. It is nothing but the maximum capacity of our lungs, how much amount of air our lungs can store. That is up to 6 liters, 6000 ml. So all the volumes and capacities, to revise that, you can refer this figure. Here it is tidal volume. This graph suggests inspiratory reserve volume, and here it is expiratory reserve volume. This is residual volume, and by combining all of this volume we will get our different lung capacities. Now control of ventilation. So as we all know breathing is voluntary as well as involuntary process. Okay, we breathe throughout the day, whatever activity we are doing, even while sleeping, breathing continues. So in a way, it is voluntary as well as involuntary. So let's understand how this breathing is controlled. So obviously it is getting controlled by the brain. So there are some centers in our brain that controls the breathing, and these centers are located in medulla and pons. So let's understand the medullary centers. There are two respiratory groups in the medulla: ventral respiratory group and dorsal respiratory group. Now, this division is based upon the location of the location of the neurons. So ventral respiratory group controls the voluntary forced exhalation, and it acts to increase the force of inhalation. Also, it regulates the rhythm of inhalation and exhalation. The dorsal respiratory group controls mostly movement of inhalation and their timing. So ventral group is associated with both inhalation and exhalation, while dorsal group is associated only with the inhalation process. As you can see in the figure, okay, this is dorsal respiratory group, and here it is ventral respiratory group located in the medulla. It gives direct commands to our respiratory muscles, diaphragm and the intercostal muscles, as well as accessory muscles. Now about the centers located in the pons. There are also two centers, pneumotaxic center and apneustic centers. So these pneumotaxic centers, they coordinates the speed of inhalation and exhalation. It sends inhibitory impulses to the inspiratory area and involved in fine tuning of the respiratory rate, like where to reduce the RR, where to increase the RR. Then comes apneustic center. It coordinates the speed of inhalation and exhalation, but it sends stimulatory impulses, while your pneumotaxic center sends inhibitory. So they are both opposite. It is overridden by the pneumotaxic control from the apneustic area to end the inhalation. Now let's understand the afferent connection to the brain stems. So these afferent connections, they come from the hypothalamic and limbic influence, from the chemoreceptors and from the lung receptors. So let's understand each of them one by one. Hypothalamic and limbic influences. Pain and emotional sensations from the hypothalamus and limbic system, they alter the ventilation via input to the brainstem. So these are the higher centers which influences the brainstem centers, that are our medullary and pontine centers. Okay. For example, in case of anxiety, there occurs hyperventilation. Okay. So our respiratory rate increases under the influence of hypothalamus and limbic system. There comes chemoreceptors. Now these chemoreceptors are of two types, central and peripheral. So first of all, what these chemoreceptors do? They are responsible for sensing alteration in blood pH, carbon dioxide and oxygen levels. Okay. So as the name suggests, chemoreceptors, they are sensitive to chemical changes in the blood. Okay. So there are two types, central and peripheral. Central chemoreceptors are located in the upper medulla. So they get stimulated when there is increase in level of CO2 in CSF. As they are located centrally in the brain, so obviously they will be sensitive to CO2 level in the CSF. So when they get stimulated in response, what the chemoreceptors will do? They increase the depth and rate of ventilation. Okay. To wash out the additional CO2 from the lungs, it increases the depth and rate of ventilation. Then peripheral chemoreceptors, they are located at the carotid artery and aortic arch. Now they are sensitive to hypercapnia and hypoxia. So what is hypercapnia? It is increased level of CO2 in our blood, and hypoxia is decreased level of oxygen in blood. Okay, so it gets stimulated when CO2 decreases, and in response what it does, it increases the ventilation. Okay. Okay, now let's discuss about the lung receptors. So there are basically three types of lung receptors: irritant receptors, stretch receptors, and J receptors. Irritant receptors, they are located in the upper airways or conducting airways. They get stimulated by any noxious gas or irritant substances or particles in the airway, and they respond by a quick cough reflex or bronchial constriction. Stretch receptors, they are located in smooth muscles of the airway that are in our bronchioles or in terminal bronchioles. Stimulation is from increasing size and volume within the lungs. They respond by a reduction in the ventilatory rate and volume. J receptors, they are located near the pulmonary capillaries. They get stimulated by increased in pulmonary capillary pressures, and in response what they will do, they initiate a rapid and shallow breathing. Now after the nervous control of our pulmonary system, the next part in the physiology is to understand the pressures, what kind of pressures exist in our lungs, and because of that we can breathe. So first of all we will discuss intrapulmonary pressure and atmospheric pressure. Basically intrapulmonary pressure is the pressure within the lungs, as the name suggests. So when the diaphragm and external intercostal muscles contract, they increase the volume of thoracic cavity and lungs. Now according to Boyle's law, this causes a reduction in intrapulmonary pressure. As pressure and volume, they are associated inversely. So whenever volume increases, pressure decreases. Okay, so that is why there is reduction in the intrapulmonary pressure, which is termed as subatmospheric pressure or negative intrapulmonary pressure. Now this pressure difference between the atmosphere and the lungs, that will facilitate the flow of air into the lungs and normalizes the pressure difference. So whenever we do inspiration, pressure in our lungs falls. So air will travel through the area of high pressure to low pressure. So from the atmosphere, the air will go into our lungs. So that was the basic mechanics of breathing. So that is known as negative pressure breathing. Now what happens during mechanical ventilation? Let's understand that. So whenever the patient is placed on mechanical ventilation, they lack the ability to generate an effective negative or subatmospheric pressure, which is the normal mechanism. So in light of this, the mechanical ventilator forces the air into the lung through creation of a positive pressure that is greater than the atmospheric pressure. That is why patients on mechanical ventilation, they often demonstrate reduced strength of inspiratory muscles, and due to the diffuse atrophy as the ventilatory muscles, they assist with the breathing. Okay, so now muscle doesn't have to work, all the work is done by the mechanical ventilation. Okay, so the muscle will go into the disuse atrophy, and that will lead to muscle weakness. Now, this patient may benefit from the breathing exercises, positioning, and use of inspiratory muscle trainer to improve and maintain function of the inspiratory muscle. Okay, so this is also a very important concept, that why a patient on mechanical ventilation, they are at risk of getting atrophy and weakness of the inspiratory muscles. Now let's understand intrapleural pressure. So there exist two opposing forces, including an inward pull from the elastic tension of the lung tissue that is trying to collapse the lung, and an outward pull of the thoracic wall that is trying to expand the lung. Okay. So first of all, intrapleural pressure, that is the pressure between two layers of pleura. As you all know, there are two layers of pleura. Outer layer is parietal pleura. Inner layer is visceral pleura. Okay. So basically what happens, our lungs are continuously in the tendency to get collapsed. Okay. And our thoracic cavity, it tries to open up the lungs. So between these two types of pressure, two types of force, there occurs a intrapleural pressure, okay, between the two layers of pleura. So these two opposing forces gives rise to a subatmospheric pressure or negative pressure within the intrapleural space, that is intrapleural pressure. Now this intrapleural pressure is normally lower than the intrapulmonary pressure that is developed during both inspiration and expiration. Now this is important. Intrapleural pressure is always lower than the intrapulmonary pressure. Just remember that. Now what is transmural pressure? Transmural pressure considers the difference between the intrapulmonary and intrapleural pressure. The difference between these two pressure is your transmural pressure. The inner pulmonary pressure is relatively greater than outer intrapleural pressure, allowing the difference in pressure to maintain the lungs near the chest wall. Otherwise, the lungs will collapse. It is the transmural pressure or transpulmonary pressure that allows the changes into lung volume parallel to changes in the thoracic excursion during expiration and inspiration. Let's understand with this figure as well. Now in the first part, as you can see, at the end of expiration, what happens, both level in the lungs and in the atmosphere, the pressure is same, so there is no flow because there is no pressure difference. Okay. Now in the second figure, during inspiration, what happens, muscles, our respiratory muscle, that they get contract. Okay. So it will create a negative pressure over here, minus 23 centimeter H2O. So that is the pressure created into our lungs, that is our pulmonary pressure. Okay. Now here the pressure is 0 centimeter. So from high pressure point, the air comes to the low pressure point. You can see flow in, so the air flows in towards the negative pressure into our lungs. Now in intrapleural pressure, it is 30 centimeter H2O. Okay. And if we calculate transmural pressure, that is the difference between our intrapulmonary pressure and intrapleural pressure. So that is 7 centimeter H2O. Now because of this transmural pressure, the shape of our lung is maintained. Okay, the lung stays towards our chest, okay, attached to our chest and doesn't get collapsed. Okay, so this was all about the pressures that exist in our lungs. They participate into the process of breathing, inspiration and expiration. Okay, now other than pressures, there are four main characteristics of our lungs. Okay, so let's discuss them one by one. First of all, we will discuss about the compliance. So compliance is nothing but the ability of our lung to distend, ability to expand. So we can compare our lungs with the balloon. Okay, so how the balloon gets inflated when we force air into that. So similar to that, when we do inspiration, our lung gets inflamed. So it gets distended. So this ability to distend, it is known as compliance. So by proper definition, it is defined as change in the lung volume per change in the transmural pressure or transpulmonary pressure. So compliance is expressed as delta V divided by delta P. So the compliance is reduced as the lung approaches its TLC, that is total lung capacity. Okay. So at the end of full inspiration, when our lungs are filled with air, there is limited amount of compliance. So up to certain level our lungs can expand. After that they cannot expand. Okay, where it becomes relatively stiffer and less distensible, because now there is no room for air as all the fibers are already stretched and to their maximum capacity. Now let's discuss it with the disease physiology. So how the compliance gets affected in different diseases. So first let's discuss about COPD. Okay, so in case of patient with COPD, our lung compliance will increase. That means lungs becomes more distensible. So their ability to store amount of air will increases. Okay, as there occurs air trapping in COPD. Okay, now inversely, in case of pulmonary fibrosis or any restrictive diseases, the compliance will reduce. So the lungs will become more stiffer. Okay, because of the process of fibrosis, the fibers of the lungs, the collagen fibers, they become more resistible to the distension, and because of that the patient cannot get enough amount of air during the inspiration. Okay, so that is why the patient of pulmonary fibrosis, they are always in air hunger. Okay, they cannot do inspiration fully. When you ask the patient to take a deep breath, they cannot do it because of their stiffer lung. Okay, reduced amount of compliance. Now let's understand about elasticity. Elasticity refers to the tendency of a structure to return to its initial size after being distended. Okay, simple. Let's take example of any rubber or any spring. So when you stretch it and when you remove the stretch, it comes to its normal shape. That is nothing but the elasticity. So our lungs has the similar property to come to its initial size after being distended. So a network of elastin and collagen fibers within the alveolar wall and surrounding bronchi and pulmonary capillaries, that will provide the elastic properties to the lungs. So, okay, so it is elastin and collagen fibers which are responsible for elasticity. Now let's understand about the resistance to air flow. Okay. Now as we all know, the air moves into and out of our lung. So there is some amount of resistance that is offered by our lungs to the air. So the ability to inflate the lungs with air, that depends on the pressure difference and resistance to airflow. So whenever there is high resistance, there will be reduced airflow. Okay. So basically our upper airways, they are mainly responsible for most of the airway resistance due to the turbulent airflow. Now upper airways means our trachea, lobar bronchi and mainstem bronchi. So they are conducting airway. So in that airway, in upper airway, the airflow is turbulent type. So they offer the most amount of resistance to the airflow. As you can see in the figure, here upper airway, the airflow is like this. This is known as turbulent airflow. Okay. While in the lower airways near your alveoli, the airflow is lamellar. This kind of airflow, it is known as lamellar and airflow. So this kind of airflow will offer low amount of resistance. Now, airflow resistance that also depends on the diameter of the airway, and the diameter of airway that is again influenced by our sympathetic and parasympathetic nervous system. So what our sympathetic nervous system will do, stimulation of sympathetic system, there will cause bronchodilation. That means increase in the airway diameter. Here you can see the airway is wide. So whenever there is increase in the airway diameter, resistance reduces. Okay, and under the influence of parasympathetic system, there occurs bronchoconstriction. So the diameter will reduce, and because of that, the airway resistance will increase. That is why in patients with asthma, in such patients, there occurs bronchoconstriction and increased amount of mucus production and mucus secretion, and because of that there is increased airflow resistance and they cannot breathe. They produce a wheezing sound because of high resistance. Okay, so that was all about resistance to airflow. Now let's discuss surface tension. So in the lung, there is a thin film of fluid on the alveolus that has surface tension. It collapses the alveolus and increases the pressure of air. Now, basically what is surface tension? So whenever there is air fluid level, so this both layer, they tend to stick to each other. Okay, it is very difficult to pull the both layers apart. So similar structure is in our lungs because of the substance called surfactant. So what is surfactant? Let's understand that. The principal active ingredient of surfactant is DPPC, that is dipalmitoyl phosphatidyl choline. I know it is very difficult name, but you can remember it by DPPC. So that is the main component of the surfactant. Now this surfactant creates a layer throughout the alveoli. Okay, so the structure of this surfactant is such as it presents two layers. One is non-polar layer, that is the end of fatty acid that is insoluble in water, and another layer is polar end that dissolves into the water. So the rate of change in the surface tension resulting from compression of the surfactant molecule as the alveolus gets smaller is faster than the rate of change of decreasing alveolar radius. So there is a point so that a point is rapidly reached in which the pressure in the small alveolus equals the pressure in the big alveolus. Okay, now this is a difficult concept to understand, I know. So let's understand this with this figure. So there are different size of alveoli in our lungs. Okay, it is not like that all the alveoli are of similar size. Okay, there might be some small alveoli and some bigger alveoli. Okay, so basically what happens, this small alveoli, they tends to get collapsed early compared to this bigger alveoli. Okay, why? Because air from this alveoli, it goes into the bigger alveoli. Okay, now to prevent that from happening, there is our surfactant. Okay, it prevents that from happening, keeps both sides of alveoli open. Now because of this surfactant, it doesn't allow our small alveoli to get collapsed. Okay, why? Because it prevents the pressure reduction in the smaller alveoli, so that the pressure between both the alveoli becomes equal. Okay, here you can see delta P1 pressure in this alveoli and delta P2, they both are equal. Okay, so there will no air exchange between them two. Okay, So in the presence of surfactant, the surface tension is reduced as intramolecular forces are homogeneously generated between water-water and water-air phase, avoiding bending of the air-liquid interface and avoiding alveolar collapse. Okay, so these small alveoli that can't collapse up to certain amount. Okay, and it remains open. That is the main function of our surfactant. Okay, so that was all about ventilation. I hope you all had a clear idea of what is ventilation, what are the pressures, pressure differences, and the properties of the lungs. Now, the second important concept is respiration. Okay, so what is respiration? It is the process of gas exchange in the lungs facilitated through the process of simple diffusion. Now, once the air has arrived into our lungs up to the alveoli, now whatever happens is respiration. Okay, and respiration is facilitated by the process called diffusion. Now, for diffusion to occur, there are two requirements. First is air bringing in oxygen into the lungs, that is alveolar ventilation, and blood to receive oxygen and give up carbon dioxide, that is perfusion. Okay, respiration between alveoli and pulmonary artery occurs across a semi-permeable membrane, that is alveolar capillary membrane. It is also known as respiratory membrane. In this figure here you can see this is our alveoli, here is air, this is the capillary. Now both of this, they are in very close contact. Okay, and between them two there is a layer, a membrane, which is known as respiratory membrane. Okay, through this respiratory membrane our carbon dioxide goes into the lungs and oxygen gets into the blood. Okay, at the level of alveolar capillary interface. So this process is respiration, movement of oxygen and carbon dioxide between alveolus and capillaries, and the process is known as diffusion. Now diffusion happens due to pressure difference from high pressure area to low pressure area. That is a diffusion method. To allow for effective gas exchange to occur between the alveoli and pulmonary capillary, different partial pressure of oxygen and carbon dioxide must exist in each of the two areas. As I just said, diffusion is based upon the pressure difference. So there are different partial pressure of oxygen and carbon dioxide in our lung. The differences in partial pressure of each gas within alveoli and pulmonary capillary, that creates a pressure gradient across the respiratory membrane. This gradient will enable the gases to diffuse from area of high concentration to area of low concentration. Okay. Now, what is perfusion? Perfusion refers to the blood flow to lungs that is available for gas exchange. Pulmonary circulation system is termed as low resistance and low pressure pathway. So the pressure within the pulmonary capillaries are very low compared to our systemic circulation, our systemic capillaries. The perfusion of the lung is affected by alteration in partial pressure of oxygen within the alveoli and also affected by changes in the blood pH. So how much amount of blood will go into our lung, that will depend upon the oxygen level of the body and also the pH of the body. Now, ventilation and perfusion matching. So for optimal respiration or optimal gas exchange, the distribution of gas and blood at the level of alveolar capillary interface must be matched. Okay, so the lungs must receive enough amount of air as well as enough amount of blood for optimal gas exchange. So the positions play a very vital role in distribution of ventilation as well as perfusion. So different body position has a very much influence how the ventilation and perfusion is in particular lung area. A change in the position of patient changes the area of ventilation and perfusion. Generally what happens, greater ventilation and perfusion occurs in gravity dependent areas and thereby allowing better respiration to occur in dependent lung when the individual is in sideline position. Okay, so whenever we give sideline position, for example we are giving right sideline position to the patient, so the right lung is down and left lung is up, so there will be more amount of blood pulling in our right lung because it is downward. Okay, so there will be more ventilation and perfusion in the right lung. Okay, so we have to give position to each and every patient considering this concept, ventilation and perfusion matching. Now what happens in upright position? Okay, so in upright position, gravity allows for greater amount of blood or perfusion at the base of lung compared to our apex of the lungs. In addition, alveoli in the upper portion or apices of the lung have greater RV. RV is residual volume, okay, which are subsequently larger. Okay, so there will be more amount of air in the upper alveoli compared to the lower alveoli. So the larger alveoli have greater surface tension and have relatively more difficulty inflating because of the less compliance. Because they are already larger in size, they cannot expand after a certain level. Okay, that is why it is more difficult to inflate such alveoli compared to the small alveoli. Okay, so in light of this, ventilation and perfusion are relatively greater towards the bases of the lungs. That means lower lobes of the lungs, favoring the better matching and resultant respiration and gas exchange. Okay. So based on this concept, our lungs are divided into 3 zones, also known as west zones of lungs. Okay, so upper part of the lungs, you can say the upper lobes, they are zone 1. Now in this zone 1, there is more ventilation compared to perfusion. As you can see, the capillary is collapsed over here, okay, which shows less amount of perfusion compared to ventilation. Okay, so air will be less, but blood will be air will be high, but blood will be less. Okay, now in zone 2, there will be enough amount of blood as well as enough amount of air. So both will be in equal amount. And at the basis, there is zone 3, where there will be more amount of blood and less amount of air. That is due to effect of gravity. So here perfusion will be high, but ventilation will be low. Okay, so now when we compare all 3 zones, so there is optimal ventilation and perfusion in the middle zone. Okay, so it is considered as V by Q ratio. Okay, ventilation and perfusion matching, we can say it is V by Q ratio. So that is optimal in the middle zone. Okay, zone 2. Okay, now there is also one concept known as shunt and dead space. Okay, based upon ventilation and perfusion. So basically, what is shunt? So shunt is the area where blood supply is enough, but there is no ventilation. Okay, so here ventilation and perfusion ratio will be very low. Okay, now in case of dead space ventilation, what happens? There is enough amount of air, but there is no blood to receive the oxygen and give up the carbon dioxide. Okay, so ventilation gets wasted in this area. That is why it is known as dead space ventilation, and a ventilation perfusion ratio will be very high in this area. Okay, while in the normal situation with optimal ventilation and perfusion, there will be equal ratio up to 0.8. So the normal value for V by Q, ventilation by perfusion, should be 0.8. Okay, that is the optimal value. Now, to measure this ventilation and perfusion matching, whether the patient is receiving enough amount of blood or air, okay, they are receiving enough air or not. Okay, so how we can measure that? So the effective non-invasive tool to measure it is pulse oximeter. We all have used pulse oximeter, right? So we are all familiar with that. It is very important for clinicians to monitor pulse oximeter readings and observe for signs of distress when changing the patient position. That will alter the V by Q matching. So obviously whenever we give different positions, ventilation and perfusion will change, and that will also be reflected in our pulse oximeter reading. Abnormal VQ ratios cause concomitant reduction in pulse oximetry and are noted in patient with the respiratory diseases such as pneumonia, pulmonary embolus, edema, emphysema, bronchitis, all the other pulmonary disorders. Whenever give different type of position, it will alter the amount of SpO2 in the pulse oximeter. So that is nothing but the ventilation and perfusion matching. Okay, so the value that we get, 99% of oxygen, 90% of oxygen, what that suggests? It suggests how much optimal the ventilation and perfusion is. Okay, and that is a non-invasive and most commonly used tool. Okay, now the third part, after discussing ventilation and respiration, the third part was transport of gases. Okay, so we will discuss for oxygen and carbon dioxide, how these gases are being transported. So the majority of oxygen is transported to the peripheral tissue bound to the hemoglobin. So hemoglobin is present in our red blood cells, and the remaining 2% of oxygen that gets dissolved in plasma within the blood. So the oxygen carrying capacity of the body, that is determined by the concentration of hemoglobin. Okay, so this is the molecule of hemoglobin. It has 4 chains, 2 alpha chains, this 2 alpha chains, 2 beta chains, and 4 heme groups. Okay, these purple ones, they are heme groups. Oxygen gets connected to these heme groups. Okay, so one molecule of hemoglobin can contain 4 molecules of oxygen. Okay, so once this hemoglobin binds to the oxygen, it is known as oxyhemoglobin. Okay, so via this oxyhemoglobin, oxygen gets transported to the tissue. Now, how the carbon dioxide gets transported? So after the metabolism at the cellular level, okay, once there is a process of metabolism, the byproduct will be water and carbon dioxide and energy. So now this waste product, carbon dioxide, how this gets transported to lungs, from the peripheral tissue to lungs. So there are main 3 methods. First is dissolved carbon dioxide, second is carbaminohemoglobin, and third is by carbonic acid. So first discuss about dissolved carbon dioxide. Carbon dioxide released from the tissue that may get dissolved in blood and plasma and get transported through the system. Means directly from the blood it gets transported to the lungs. Okay, so but a very small amount of carbon dioxide is transported in this way, only about 7 to 10%. Then carbaminohemoglobin. So the carbon dioxide that gets attached to hemoglobin, similar to oxygen. Carbon dioxide can also combine with hemoglobin molecule, which is known as carbaminohemoglobin. It will bind to the protein chains rather than the heme components. Okay, So carbon dioxide will get attached to the alpha chains and beta chains. So the complex formed from binding of the carbon dioxide and hemoglobin, it is known as carbaminohemoglobin. Only about 1/5 of the total carbon dioxide is transported in this way, about 30 or 20% you can say. Now the remaining carbon dioxide will be transferred in the form of carbonic acid, okay, or bicarbonate you can say. Now as I said, after any metabolic process, the byproduct is water, H2O, and carbon dioxide. Okay. Now this carbon dioxide that goes into red blood cell. Okay. Now all this thing is happening at our tissue level. Okay, around any cell. Okay. Now carbon dioxide and water, they get combined and will become H2CO3. Now there is an enzyme carbonic anhydrase that will facilitate this process, formation of carbonic acid. Now this H2CO3, it is very unstable particle or unstable substance. So that will be that will form H plus and HCO3 minus. Okay, they both will separate. Now this H plus, it will bind with the hemoglobin present in red blood cells. Okay, and the HCO3, it will go into the plasma and get dissolved. Now because HCO3 is, it has negative property, okay, HCO3 minus. So once it goes outside of the red blood cells, there has to be equal amount of ions, negative ions in the red blood cells. Okay, so to equalize the ion amount, chloride from the plasma, it will get transported into red blood cells. That is known as chloride shift. Okay, this all process, it will happen at tissue level, at your cellular level. And maximum amount of carbon dioxide is transported in this way, around 70%. That was all about the physiology of pulmonary system. So we learned some important concepts like ventilation, respiration, and transport of oxygen and carbon dioxide from blood to the air, okay, from blood to the lungs. So that was all. Now we will discuss about the cardiovascular system. Okay. So directly jumping on to the anatomy of cardiovascular system. So the main organ is our heart. It has 4 chambers, as you all know. I'll just quickly revise the anatomy. Right atrium and left atrium, 2 ventricles, right ventricle and left ventricle. There are 4 valves. Between right atrium and ventricle there is tricuspid valve, and between left atrium and ventricle there is mitral valve, also known as bicuspid valve. There is pulmonary valve and aortic valve. These valves are also known as semilunar valves. Major vessels that arises from heart, they are pulmonary artery and aorta. And the major vessels that gets empty into the heart, they are inferior and superior vena cava and 4 pulmonary veins. Now let's quickly understand about the blood circulation in our body. Okay, so from the entire body, the deoxygenated blood, the blue one, CO2 rich blood. So this deoxygenated blood, that will come to our right atrium via the veins. All the veins gets empty into superior and inferior vena cava. This vena cava will empty into right atrium. Now from the right atrium, blood will go to right ventricle through mitral valve. Now from the right ventricle, blood goes into our lungs via pulmonary arteries. Okay. Now gas exchange occurs in the lungs. Just we learned how that happens, and the oxygen rich bloods, it gets collected in the pulmonary veins. Okay, now these pulmonary veins, they empty into left atrium. Now from left atrium, blood goes into left ventricle through mitral valve or bicuspid valve. Now this from this left ventricle, blood will go into aorta, and from aorta it will get distributed in the entire body, and the process will repeat itself. Okay, that is why it is known as blood circulation. So there are two major circuits, systemic circuit and pulmonary circuit. Systemic circuit is a high resistance and high pressure circuit, while pulmonary circuit, pulmonary circulation is very low pressure and low resistance system. Okay, just remember that. So the primary function of our cardiovascular system is transport and distribution of essential substances to the tissue of the body, and removal of the byproduct and any waste materials of cellular metabolism. That is nothing but the carbon dioxide. The heart provides the principal force that pushes blood through the vessels of the pulmonary and systemic circuits. In case of the systemic circuit, the forward movement of blood is also facilitated by recoil of the arterial walls during systole. During systole, whenever the heart contracts, the arteries, they also contract and pushes the blood forward. Okay, that is a driving force for the blood into the systemic circulation. Skeletal muscle compression of veins during exercise, and negative thoracic pressure during inspiration. So all the three components, they will assist the heart to pump blood through our entire body. Now what we will learn in the cardiovascular physiology, that are cardiac cycle. First of all, we will learn about it. Then what is cardiac output? Okay. Then ejection fraction, what is venous return, coronary blood flow, and last is blood flow regulation while we are doing exercises. So these are the important concepts in cardiovascular physiology. So let's start understanding one by one. First of all is our cardiac cycle. So the period from beginning of one heartbeat to beginning of next, it is known as cardiac cycle. Okay, simple. Beginning with an action potential into SA node, that is sinoatrial node. A depolarization wave is spread through both the atria to the atrioventricular node. Okay. So the action potential that will be generated in the SA node, that will travel to AV node. Then through His and Purkinje complex, it will get conducted to ventricles. However, because of the nature of specialized conduction system, the impulse is delayed for about 0.1 second. Okay, it is a very less amount of time, a fraction of a second, in the upper 2/3 of the AV node. Now because of this delay, there occurs a mechanism known as atrial kick. Okay, so let's understand what is that. This allows the atria to contract and pump additional volume of blood into the ventricles. After one contraction, due to delay for about 0.1 second, both the atriums, they again contract with a higher amount of force. That is known as atrial kick. So the ventricles provide the primary force to move the blood through the vascular system. From the atria, blood goes into ventricle, and ventricles are the primary chambers that forces the blood into both the systems. Okay, now this is the conduction system of the heart. Here this is SA node. From this the impulse will travel to the AV node. Now for this for this impulse conduction, there is 0.1 second delay, and because of this atrial kick will happen. Now from SA node, the impulse will travel to the ventricles. Okay. Now let's understand cardiac cycle by this figure. So first of all, as we just learned, atrial contraction will happen. So there are basically two phases in the cardiac cycle. One is systole, another is diastole. So during systole, the muscles will contract, and during diastole, the muscle will relax. Okay. So during atrial systole, what happens? Atria will contract and a small amount of blood enters the ventricle. Okay, as you can see, the blood is going from atria to ventricle. Okay. Now what happens? Isometric contraction. Now at this stage, all the valves are closed in the heart. So ventricles undergo isometric contraction and pressure in the ventricles will increase. Now blood is in the ventricle. Because of all these valves closed, there is no pressure difference, and without any pressure difference, blood cannot travel from one chamber to another chamber. Okay, remember always, whether it is air, whether it is blood, any kind of fluid or material it is, there needs some amount of pressure difference for movement to occur. Okay, so in the heart, because every valves are closed, all the four valves, the ventricles will contract isometrically. That means the length will not change, only the pressure will build up in the ventricle. Then comes ejection period. Semilunar valves are opened. Okay, now as the pressure will increase in both the ventricles, what happens? Both the semilunar valve will open. They are your pulmonary valve and aortic valve. Okay, and because of that, the ventricle will contract and blood will pushed out of both the ventricles. So from the right ventricle, blood will go into pulmonary artery, and from left ventricle, blood will go into aorta. Okay, simple, understood up till now? Now what happens? Protodiastole. Now once contraction is happened, relaxation will start, okay, which is known as diastole. This is the first stage of diastole. The semilunar valves are closed at the end of this period. Now once the blood is emptied into both these vessels and pressure is equal between the ventricles and both the arteries, now this valves gets closed. Okay. Now what happens? Isometric relaxation, just similar to isometric contraction. The length of ventricle will not change. All the valves are closed. Ventricles will undergo isometric relaxation and pressure in the ventricle will reduce. There comes rapid and slow filling phase. Now atrioventricular valves will open. Why? Because the pressure in the ventricles will reduce, and that will lead to opening of both the tricuspid and bicuspid valves, and ventricle relaxes and filling occurs. Okay, because the pressure is low in the ventricles. Okay, so the blood will move through aorta to ventricle. Okay, clear? And by the end of this phase, one cycle is complete. Okay, now again the atrial systole phase will come and the cycle will happen again. Okay, the total duration of this entire cardiac cycle is 0.8 second. Okay, so in time of less than 1 second, all this process will happen and blood gets pumped from our heart. Okay, with that cardiac cycle is complete. Now we'll discuss about cardiac output. The cardiac output reflects the volume of blood that is ejected out of the left ventricle into systemic vasculature per minute. Okay, remember cardiac output is amount of blood that comes out of heart per minute. Okay, now minute is very important to understand cardiac output. It is the function of number of heartbeats per minute and the volume of blood ejected per beat. Okay, now let's understand. Cardiac output is a product of heart rate and stroke volume. On average, the cardiac output at rest is between 4 and 6 liter per minute to allow for sufficient tissue perfusion. Okay, so every minute our heart pumps around 4 to 6 liter of blood into our body. With exercise, increase in the cardiac output is warranted. Okay, so it is not like that we will need this much amount of blood during every activity. Okay, we will need more amount of blood, more amount of oxygen whenever we are doing some activity. Metabolism will increase. For example, we are exercising, okay, or any exercise, running, jogging, or simple household work. Okay, there will be increased metabolic demand, and to satisfy that demand of oxygen, metabolic rate has to increase, and this is fulfilled by increased cardiac output. To allow for this increase in cardiac output, increase in the blood volume must also exist. Okay, so how this cardiac output gets increased? Obviously, either there will be increase in the heart rate, or there will be increase in the stroke volume, or increase in both of that. Ultimately, it will cause increase in cardiac output. So let's understand how that happens. First is regulation of heart rate. So how our heart rate is regulated in the body. The heart continues to beat automatically between 60 to 100 beats per minute as long as the myocardial cells are alive as a consequence of spontaneous depolarization from SA node. That is a self pacemaker of our heart. Now, sympathetic and parasympathetic nerve fibers to the heart, they are activated to alter this instinct pacing rate that is generated by the SA node. See, normally into day-to-day activity, the heart maintains its rate by its own, that is 60 to 100 per beats per minute. But whenever we do some activity, the heart rate needs to be changed. Okay, it cannot be same all the time. Okay, so how this heart rate gets changed? It is influenced by autonomic nervous system, that is our sympathetic and parasympathetic nervous system. So let's see how that happens. Okay, so epinephrine from the adrenal medulla of the adrenal gland. Adrenal gland is attached to our kidney, that is one hormonal gland of our body. Epinephrine is a hormone that is under the influence of our sympathetic nervous system. So epinephrine and norepinephrine, also known as adrenaline and noradrenaline, they open the channels of pacemaker cells of SA node and they increase the rate of depolarization, resulting in an increase in heart rate. Okay, so you all might have heard about adrenaline rush. Okay, that is a very popular term, adrenaline rush. So a state of excitement increased in heart rate. Okay, so that is the physiology behind that. So under the influence of a sympathetic system, the hormone adrenaline, it will increase our heart rate. Okay, that is adrenaline rush. You can remember this by adrenaline rush term. Okay, that will be very easy to remember. Now, what happens under the influence of parasympathetic nervous system? So it is achieved through the release of acetylcholine, that is again a hormone. So it is released by vagus nerve endings that bind to the acetylcholine receptors in our heart, that slow down the rate of action potential production and thereby they depress the heart rate. Okay, just opposite to the sympathetic nervous system. Now, based on this, there are two important concepts: chronotropic effect and inotropic effect. Okay, so let's understand what is that. First is chronotropic effect. So mechanism that alters the cardiac rate, our heart rate, that is said to have a chronotropic effect. influence that increases the heart rate, it is said to have positive chronotropic effect. Okay, that is under the influence of sympathetic system. Whereas those mechanism that decreases the heart rate, that is negative chronotropic effect. Okay. Now, inotropic effect. Mechanisms that affect the contractility of myocardium that are said to have inotropic effect. So those that increases the contractility, that is positive chronotropic effect, and the effect that reduces the myocardial contractility, that is negative inotropic effect. Now under sympathetic stimulation, vasodilatation occurs in the coronary arteries to increase blood flow, and that increase in blood flow, it will increase the myocardial contraction, thereby generating positive inotropic effect. And just opposite thing happens with parasympathetic influence. It will depress the myocardial contractility by vasoconstriction of the coronary arteries. Now, based on this concept, there is a clinical influence in case of patient taking beta blockers. So the patient who are on beta blockers have a blunted heart rate response during the exercise, as the beta receptors on the myocardial, they are unable to respond to the sympathetic stimulation and appropriately increase the heart rate. Okay, so beta blockers drug, these are most commonly used drug among the cardiac disease population. Okay, so whenever the patient is taking drug while exercising, patient's heart rate will not increase up to certain level. Okay, this is because of the influence of blockage of beta receptors. Okay, so the hormones from the sympathetic nervous system, that is our adrenaline, noradrenaline, they cannot bind to the muscle, they cannot bind to the coronary arteries, and because of that the heart rate cannot increase. Okay, so in light of this, it is effective to use a subjective assessment of intensity, that is Bog scale, Bog rate of perceived exertion, as the objective measure of intensity during the exercise. Okay, so remember, whenever you are dealing with any patient having heart diseases, okay, whether it was in past or present, or whether the patient is taking beta blockers, you cannot rely on patient's heart rate. Okay, because it is not a proper indicator of actual load on the heart. Okay, so you have to go for Bog scale to determine how much intensity of exercise should be there. Okay, so just remember whenever you are dealing with cardiac patient. Now let's understand regulation of stroke volume. So as just we discussed, stroke volume is a volume of blood ejected out of the heart per beat, that is affected by three variables. Okay, preload, contractility, and afterload. First of all, what is preload? The preload is a reflection of the volume of blood returning to the heart. It is often correlated with the end diastolic volume, which is the maximum amount of blood that can be in the ventricles immediately prior to contraction. Okay, so let's understand it in an easy way. Just before the ventricle is to contract, the amount of blood in the ventricle, that is end diastolic ventricle, end diastolic volume. So whenever the ventricles are relaxing, how much amount of blood it can store, that is our preload. In normal cardiovascular physiology, the preload is directly proportional to the stroke volume. Okay, so higher the end diastolic volume, higher the stroke volume. Okay, obviously if there is more amount of blood, more will be ejected out of the ventricle. In other words, as more blood returns to the heart, greater volume of blood leaves the heart with every contraction. Okay, just as I said. So within physiological limits, the strength of ventricular contraction resulting in increased stroke volume, it varies proportionally to its pre-contraction length, which is influenced by the volume of blood in the ventricles prior to contraction. Now, this concept is termed as Frank-Starling mechanism. So, this is a very popular concept in our biomechanics. So, any muscles pre-contraction length is very important. Okay. If the pre-contraction length is high, it increases. Then contraction will also increases. The strength of contraction will also increases. So similar concept is applied in case of muscles of heart, our cardiac muscles. It explains how a greater volume of blood is ejected out of the ventricles when a greater volume of blood is returned to the heart. Okay. If more blood will get into the ventricles, it will lead to a stretch on the ventricular muscles. The ventricular cavity will get filled with more amount of blood, and due to that the precontractile length will increases, and due to Frank-Starling mechanism the strength of ventricular contraction increases, and because of that stroke volume will increase. Clinically, this term preload, it is directly influenced by end diastolic volume, that refers to amount of stretch on the myocardial wall just prior to contraction. In other words, it refers to the load on the myocardial wall prior to or pre-contraction. Okay? Higher the stretch, higher the contraction, and more amount of blood will be ejected. That is stroke volume. Now, what happens to the patient with heart failure? Let's understand that. So it is interesting to note that in patients with congestive heart failure, a resultant failing heart, there is an increase in the end diastolic volume, but it does not produce an increase in the preload and subsequent increase in the stroke volume. Now, why this happens? Because what happens in the heart failure, the ability of the myocardium to contract, it decreases. Okay, even though the end diastolic volume will be high, stroke volume will not be generated because of the failure of the heart muscles to contract. Okay, therefore a variety of treatments are geared at reducing the preload or stretch on the myocardial wall. Okay. Because if the preload will high, it will give more stress to the myocardial muscle, and we don't want that more stress on muscles when the heart is in failure. Okay, it will worsen the condition rather than improving. So how we reduce the preload? So one such intervention appropriate in physical therapy practice is to position the patient appropriately to help adjust the preload in patient with left side heart failure. So how we position our patient during exercise is also important. Patient with heart failure will often not tolerate supine position or recumbent position. So when the effect of gravity are minimized and the greater volume of blood will return to the heart. So whenever our patient is in supine position, the amount of blood that returns to the heart, it will increases, and that will give more load, more preload to the heart. This increases the volume, puts greater load and greater stretch on heart, causing blood to back up into the lungs and exacerbate the signs and symptoms. The patient will feel suffocated. Patient will have shortness of breath and heaviness in chest in supine position. Okay. So whenever you are dealing with a patient with heart failure, whether or not heart failure is a primary diagnosis, the patient might be visiting you for any other condition. Let's say upper limb fracture or lower limb fracture. Okay. So rather than giving any exercise, any resistance exercise in supine position, it is beneficial to give high sitting position or semi-fallows position, okay, or upright position. That will be better compared to supine position. So always consider positioning your patient whenever your patient has any heart condition, particularly heart failure. Okay. So other systemic history is also important while you are treating any kind of patient, whether it is ortho patient, whether it is neuro patient. Okay. So complete history taking is very important. Then only you will get to know what kind of other disease or diagnosis the patient is having. Okay, understood? So this patient will better tolerate upright position. Okay. So in upright position, most of the blood will get pulled into the legs because of effect of the gravity. There will be less amount of stress in the heart. Now let's understand about the concept of contractility. Myocardial contractility is influenced by intrinsic factors and extrinsic factors. So intrinsic factors, they are happening into the heart, and extrinsic factors, they are influenced mechanisms outside of the heart, you can say. The intrinsic control of contraction strength is as a result of degree of myocardial stretch that is caused by change in the end diastolic volume, just as we discussed in the previous concept in preload. In addition, force frequency relationship causes an increase in the myocardial contractility when heart rate increases. Okay, so physiologically, at the higher heart rates, an increase in availability of calcium ions will allow for excitation contraction coupling and a resultant stronger contraction. Okay, so ideally, physiologically, what should happen, if the heart rate increases, also the force of contraction should increase, but this does not happen every time. Okay, this is under ideal physiological condition. So the extrinsic control of contractility that depends upon the activity of sympathoadrenaline system. So epinephrine from the adrenal medulla and non-epinephrine from nerve endings, that will produce positive inotropic effect. Okay, just remember, as we have discussed in previous slides, previous concept, inotropic effect. Okay, or increase in the myocardial contractility by promoting an influx of calcium available to sarcomeres and to the myocardial cells. That will obviously increase the myocardial contractility. Conversely, a reduction in sympathetic stimulation as well as reduction in heart rate, that will result in reduced myocardial contractility. Okay, simple. Now comes afterload. What is afterload? So blood flows from areas of high pressure to areas of low pressure. Okay, the concept of diffusion. Therefore, to enable blood to be ejected out of the ventricle into aorta, the pressure generated within the ventricle must exceed the pressure within the aorta. Okay, the pressure in the ventricle should be high compared to aorta. Then only the blood will go from ventricle to aorta. Okay. Now the pressure within the arterial system during diastolic phase of cardiac cycle, that is a function of total peripheral resistance. Okay. An increase in the total peripheral resistance will increase pressure within the systemic vasculature. The afterload is a reflection of pressure against which the heart has to contract to pump the blood into the aorta. Okay, how much amount of pressure or how much amount of resistance our vasculature is giving to the heart, that is afterload. Okay, the total peripheral resistance presents a hindrance or resistance to the ejection of blood from the ventricles, or represents an afterload on the ventricle wall after the contraction has begun. The afterload is inversely proportional to the stroke volume. Okay, there is an inverse relationship. If the pressure will be high, okay, if the afterload will be high, the stroke volume will low. because the heart has to pump with more force against the afterload. That is why the capacity will reduce and stroke volume will reduce. Thus, an increase in afterload or increase in total peripheral resistance reduce the amount of blood ejected with each contraction. Okay, so you can say the afterload is also one kind of your blood pressure. Okay, hypertension, in patient with hypertension, afterload will be high. So that is why the heart has to work with more power and more force, and after some time that will lead to heart failure. That is why hypertension or high blood pressure is dangerous. Okay, so this is the concept behind that, why hypertension is a risk factor for cardiac diseases. Okay, it is the concept of afterload. It is valuable to note that a reduced stroke volume from an increased afterload triggers the compensatory mechanism to maintain the cardiac output at a normal level of 5.5 liter. Okay, so whenever there is a reduced amount of cardiac output in our body, compensatory mechanisms will activate, because the cardiac output has to be at certain level. It has to be 5 liter per minute. Okay, so our body tries to achieve that in any way. Okay, so what compensatory mechanism will happen if the stroke volume reduces? So what happens? Initially, as the blood has greater difficulty being ejected because of increase in afterload, greater volume of blood builds within the ventricle, triggering the Frank-Starling mechanism. Okay, so basically increasing the preload. If the afterload increases, what happens? Our body tries to increase preload as well. Okay, and that will result into greater myocardial contraction to help increase in the stroke volume. But this mechanism that will not last longer. Okay, so after some time your heart will fail to achieve this mechanism. An inability of heart to compensate into this way will lead to congestive heart failure. Okay, just as I explained how hypertension will lead to heart failure. Okay, so this is the mechanism behind that. The compensatory increase in heart rate to maintain cardiac output at a normal level of 5.5 liter per minute. Now, the concept of ejection fraction. So in the patient's echo report, if you have seen one, there is a term known as LVEF, that is left ventricular ejection fraction. So it is very important in heart failure patient to know that what is the percentage of ejection fraction before prescribing any exercise, and based on that we have to decide that how much intensity we can keep or how much we can push the patient to do physical activity. Okay, so let's understand what is ejection fraction. It is the best indicator of cardiac function and represents a ratio or percentage of the volume of blood that is ejected out of ventricles relative to the volume of blood received by the ventricles. Now, whatever blood the ventricles will receive, it will not push the entire amount of that blood. So some amount of blood will remain into the ventricles. Okay, so the amount of blood that is ejected from in every beat, that is your ejection fraction. It reflects the ratio of volume of ejected relative to what was received prior to systole or prior to contraction. This can be mathematically presented as systolic volume divided by end-diastolic volume. So the normal ejection fraction is up to 60 to 70%. So this is the maximum amount. Okay, 50 to 60% is also acceptable. This means that for every 100 ml of blood that is poured into the ventricles, only 60 to 70 ml of blood is ejected per contraction. The remaining 30% will be in the ventricles itself. The volume of blood that remains, it is known as end systolic volume, that is approximately 30%. So there must exist a certain volume of blood remaining within the ventricles at the end of contraction to maintain certain degree of stretch into the ventricular muscle fibers. Now, in patient with systolic heart failure, the ejection fraction is compromised only by 40%. This means from every 100 ml only 40 ml of blood is getting ejected. So what happens? It will ultimately result into the reduced cardiac output. That will lead to many complications like shortness of breath, fatiguing, reduced exercise capacity, muscle aches, weakness, etc. These are the complications or you can say symptoms of reduced cardiac output. Now, what is venous return? It represents the return of blood to the right side of the heart via all these veins. So there are two factors that dictate the rate at which right atrium fills with the venous blood. So these two mechanisms are total blood volume and the pressure within the venous vasculature. Blood return to the heart is primarily returned because of the venous pressure. The mean venous pressure through entire venous vasculature is approximately 2 mmHg. So there is very low amount of pressure in the veins compared to our arteries. The pressure is highest in the distal veins. Distal veins means veins present in our lower extremities. Okay, so in lower extremity veins, the pressure will be high, up to 10 mmHg, and the pressure will be low in the vena cavas, the major veins. And this pressure difference is the driving force for blood to pull back to the heart from the peripheral to the heart. In addition, return is aided by muscle pump activity, whereby squeezing the peripheral muscle milk veins and assist the venous return. Okay, due to muscle contraction, there will be compression and relaxation of the veins, and that will pump the blood towards heart. So that is why calf exercise is very important. Also, sympathetic nerve fibers stimulate the smooth muscle cells and aids in contraction of the veins. There is another mechanism that facilitates venous return, that is pressure difference between thoracic and abdominal cavities. This phenomenon may be facilitated by deep active breathing, diaphragmatic breathing. So during contraction of the diaphragm, what happens? The central tendon, it contracts and it pulls the two hemidiaphragms downwards, that is quadrily. Okay, so this movement, it will increase the intra-abdominal pressure and there will be decrease in thoracic pressure. Okay, and this two pressure difference, because of that the blood will grow from the abdominal veins into thoracic veins. It is also noteworthy that veins have very thin walls and they are less muscular compared to the arteries, and this increases their compliance as they can distend much more with any given amount of pressure. Okay, veins have low amount of muscles in their wall compared to the arteries. In light of this, the veins have ability to hold the large volume of blood and they are often referred to as the capacitance vessels. Okay, their blood storage capacity is high, being similar to the electric capacitors. So approximately the 2/3 of total blood volume is stored within the venous vasculature. So it is often thought that Trendelenburg position, that is elevation of the pelvis and lower extremity from the supine position, it is effective for assisting the venous return, but in patients who are hypovolemic. Okay, this is the Trendelenburg position. Okay. The Trendelenburg position is not likely to augment cardiac output because of the high capacitance of the vein. It will act as a volume reservoir and counteracts any change in pressure gradient between peripheral and central veins. So the venous system is more likely to transmit pressure when the veins are overloaded and less distensible. Therefore, Trendelenburg position is more likely to assist with venous return whenever the patient has excess volume and not during episode of volume distension. Thus, using Trendelenburg position with patient in hypovolemia is not recommended. Okay. Now, coronary artery blood flow. Coronary arteries have multitude of capillaries that will help to perfuse myocardial tissue. Obviously, your heart muscle will need oxygen to continuously work without getting fatigue. Okay. So it is interesting to note that the capillary density in the myocardial tissue that ranges from 2500 to 4000 capillaries per cubic meter, while in skeletal muscle the density is only 300 to 400 capillaries per cubic millimeter. Why? Because the myocardial muscle will need more amount of oxygen to work continuously. So the heart is a muscle that survives through the constant aerobic respiration, both at rest and during heavy exercises. Thus, it is imperative that the adequate amount of blood and oxygen be constantly perfused to myocardial tissue. This is the basic structure of our coronary arteries. This is right coronary artery, left main coronary artery that will give rise to two branches. One is left circumflex artery, other is left inferior descending artery that will again give two branches, marginal artery, or you can say diagonal artery. So during systole or during heart contraction, coronary arteries are squeezed, reducing the perfusion of blood. Okay, and consequently, during coronary perfusion to the myocardium occurs more during the diastolic or relaxation phase of each cardiac cycle. So there must be adequate diastolic phase or adequate heart relaxation in order to get proper amount of coronary perfusion. So to provide a continuous supply of oxygen to myocardial cells, the myocardium contains a large amount of molecules called myoglobin. Okay, these are similar to the hemoglobin that is found into our red blood cells and have ability to store oxygen during diastole, and it releases that oxygen during systole when there is less amount of blood supply in the systolic phase to the myocardium. Coronary blood flow is also regulated by autonomic nervous system. So, fight or flight response that is triggered during sympathetic activation, okay, and that will produce vasodilatation, okay, in our coronary arteries. The sympathetic nervous stimulation will produce coronary artery vasodilatation. Okay, so there will be increased amount of blood due to vasodilatation. The diameter will increase. There will be increased amount of blood. Because of that, the cardiac output will increase. The opposite will happen during parasympathetic influence. Now let's understand blood flow to muscles during exercises. So as the body transitions from rest to exercise, blood flow pattern will change as the consequences of the actions of sympathetic nervous system. So the vessels, they contain both alpha receptors and beta receptors. Okay, so they will cause alpha receptors will cause peripheral vasoconstrictions and beta receptors will cause vasodilatation. Okay, so through the action of the sympathetic nervous system, blood can be redirected from certain organs and get shunted toward the working muscle to provide more oxygen. Okay, so during exercise, the muscles of our lower extremity, our upper extremity will require more amount of blood compared to the other organs. So how this blood will get shifted from these organs to muscles? Okay, so behind that there is a mechanism of sympathetic nervous stimulation. So the shift in blood flow to muscle is accomplished primarily by reducing the blood flow to kidneys, to intestines, to livers and stomach. So during exercise, when the active muscle experience the need of additional blood, norepinephrine release and epinephrine, what they cause? They stimulate alpha adrenergic receptors on the blood vessel of digestive organs and kidney. Now this stimulation will cause vasoconstriction of this vessel, and thereby there will be less amount of blood to these organs, to our kidney and stomach, liver, etc. And this blood gets diverted to the skeletal muscle. Now at the level of working muscle, epinephrine, same hormone, that will stimulate beta receptors, and because of that there will be vasodilatation in the blood vessel of working muscles. So all the blood that is shifted from the other visceral organs, that will be into your active muscle due to vasodilatation. Okay, so the entire blood from our body that gets shifted towards the working muscle to improve blood supply. So during exercise, this alteration in autonomic nervous system stimulation, it also influences coronary blood flow directly by affecting the heart rate and by force of contraction. That is the two primary determinants of myocardium's metabolic rate. So rate pressure product or double product, it is a clinically useful tool to estimate the myocardial oxygen demand and is calculated by multiplying the heart rate by systolic pressure. Okay, so in cardiac rehab, whenever we are conducting any exercise testing, let's say stress testing. Okay, so during stress testing protocol, we constantly monitor patients' blood pressure and heart rate. So for each stage, we have to multiply heart rate to systolic blood pressure, and this formula will give rate pressure product. Now from this rate pressure product, we will come to know that how much amount of oxygen our heart will need. Okay, so basically this formula will reflect myocardial oxygen demand. Okay, so this is a very important concept when we are doing stress testing in cardiac rehab. So during aerobic exercise, the heart rate and systolic blood pressure, there are two main factors that determine the workload on the heart, and if this factors increases, the heart has to work harder and will require more oxygen and nutrients to keep going, requiring the greater myocardial blood flow. Okay, that was all about the cardiovascular and pulmonary physiology. I hope that I have cleared your concepts and help you understand the cardiopulmonary physiology in a better way. So if you have any doubts, you can reach out to me through app in the chat section, and I'll go live to solve your doubts. Okay. Thank you so much for your attention, and we will meet in the next lecture. Bye bye.